is in this aspect there and hanging down. So we still have to know that this arm here has a mid-humerus fracture. Just gently lift it out, put the padding up, put the arm back against the body, and keeping in mind now that we've got gravity holding the arm down, so we've sort of got a self-traction process going on here, so there's no crepitus. We then feed the large Easton bandage around. And we get it just below the shoulder, leading edge in the front, and make sure it's equal across, and as firm as the patient will permit, we then strap it across with a fractured clavicle. We'll use the Easton bandage, which is equivalent to 3 narrow triangulars, and the patient obviously would be supporting. So what we do, we ask them to gently ease it out, apply the padding up inside the arm to give us our indirect traction, and we now apply the bandage. So this time we come under the arm and we come up, and with this one you make sure you follow the profile of the humerus, and notice how we now have the uniform pressure right across in an even manner there, and there, done. If we wish to, and the patient feels that there's not enough support, or we feel we want extra support, simply done, just the long narrow one under the elbow, and that's it. So if we get the patient to slowly turn around, we can now see that we've got uniform support. Ian has got on a collar that is the medium size, which really would be a bit small for him, but in some instances you'll find that we could have 2 patients that require the cervical collars. Now in this instance we can overcome the problem of the danger of it popping off all the time by just getting the small narrow Easton bandage, and it's just a matter of putting that around and securing the loose tail of the cervical collar, and this will prevent the collar popping off. You'll notice it has a special window made in the middle here. One of the uses for the window is for immobilisation and support of a fractured mandible. As we know, when the mandible is broken, we can pretty well diagnose it by asking them to just bite their teeth, and they'll have an abnormal bite. So all we need to achieve is just to take the weight of the mandible to stop it swinging. So with this, the window over the chin, make sure it's in the centre. You take the strap up the line of the mandible, over the ear, over the crown of the head, and then with this one you just apply that last little bit of pressure for the lift and apply the Velcro. And if you turn to the side end, and we now see we have complete support along the whole line, and there is no stress at all on the mandible. As with any procedure where we're going to obstruct the airway for potential vomiting or any other similar blockage, we must be prepared to be able to clear the airway immediately if that problem surfaces. So in this instance, this is one of the advantages if we needed, and the patient was vomiting, or we needed to insert an airway, simple matter of just undoing the Velcro. That's if you wish to do it. You can also advise the patient themselves, once it's applied, because it is not on very firm, you can say to the patient, if you feel like removing it and you wish to vomit or you wish to clear your airway, you can tell them just to get their hand and just pull the back of it down, and it will drop off. So this one has been specially made with a window in the centre for a couple of reasons, and one of them is for the application of lateral dressings on the skull, which sometimes can be quite difficult to put on and maintain there with a variety of triangular bandage knots and procedures. So this one we'll say the laceration is on the forehead. We take the bandage and make sure that the window is across where the laceration is under the bandage. Then we take the leading edge, if you like to turn around to the side end so we can see, under the base of the skull, back over the ear, and then a little bit of firmness, apply it on. So therefore we have the dressing now held in place. The other bonus is we've got a window into the dressing. If the blood starts perfusing through, we can see it, take it off, put another dressing on top and reapply the Easton bandage. In this case here, we'll presume the patient's conscious but is unable to walk. So in this instance, we're just going to lash them to the stretcher for their security, so that as we're going down the stairs, the patient's not going to be in too much trouble. So once again, we'll do the same as the lashing procedure. We'll go over, under the rail, And surprise, surprise, it doesn't make the journey. So the way over that is get the next smaller size and we'll add on. So we'll take this one back off, and what you're going to do is add on and bring it up, and 2 inches is sufficient for a good grip. So we'll go 2 inches up and around we go again. Making sure, if you go under the rail there and I'll go under this side, that the arms are inside the bandage, because as we know the patients unfortunately have a habit of trying to help and grabbing. And there we go. We now have the top section done, and the only one left now is the legs. Smooth edge through and meet anywhere on the legs there, and that's on. Whilst you're doing this manoeuvre, we now put on the safety belts as normal. We must make sure that the patient is reassured and does have confidence in what you're doing, because you're taking away their own instinctive ability to help themselves while we're taking them down the stairs, etc. So we'll have to make sure they're reassured while we're locking their arms up. And you require the patient to be lashed to the stretcher where the 2 seat belts are insufficient for that job. So the way we do it is, get the medium one, we go down inside the rail, across, and the offsider pulls it through the other side. Bring it back up to near the knees. He brings his leading edge over, and there's the lower legs. Next one is the big one. Once again, the leading edge. And this one, all we have to do is go under the rails, over the chest and back over again. Nice and firm. And the last one, we'll support the head with 2 sandbags, which I prefer to do, even though there may not be a cervical injury. It helps support the head from wobbling around. Leading edge through, and get your offsider to take it through. And you can put a little bit of combine over the forehead and apply for the head. Now to finish off, we put the normal belts on. And you have a very nicely secured patient onto the litter, which can be turned now at any angle without any fear of the patient falling off or any limbs moving around.